Everyone, and welcome to the May edition of the American Bifurcation Club's Bifurcation Hour. Pleased to have two excellent moderators and highly skilled interventionalists, and Azeem Latib and Abbott. Azeem has had a long history with the European Bifurcation Club and has published documents on different bifurcation techniques when he worked with Antonio Colombo in Milan. So it was apt to ask him to just briefly give us an overview of the latest consensus document from the European Bifurcation Club, actually for the meeting in Barcelona in 2019, which I was able to attend. So without much ado, we'll let Azeem present. And after that, I have three sort of similar cases for both Dawn and Azeem to moderate and ask me really tough questions about what I did and why I did it. So I'll get going with Azeem's presentation.
Thanks, Tanveer. Good to see you. Good to see you again, Dawn. It's always great to see you, and thank you everybody for joining. So this is what EBC at the ABC. I love all our abbreviations, but you know, the last EBC document was actually the 15th consensus document written by Francesco. They did a meeting last year, but it was all virtual, and there's not been an updated document. But it's always useful, I think, looking at what the EBC document says. There's some changes always, and there's some differences in practice between what's done in Europe and the US, and I think we all learn from each other. So I've only got 3 slides really, just to highlight some of the changes. So this is the general approach they talk about. And they say PCI and bifurcation stenting should adhere to a KISS. That doesn't mean you have to KISS every bifurcation. KISS means keep it simple and safe. Also systematically wire both branches, strong believer of that. Try to limit the number of stents, aim for well opposed and well expanded stents. And they use this MADS technique to report it, which not everybody uses, but I think these 4 principles are pretty good principles for everyday practice. We remain convinced, I think all of us, that a one-stent strategy is recommended for the vast majority of bifurcations, okay, and is based on a provisional side branch stenting philosophy, which means stent implantation in the main branch, eventually followed by side branch intervention stenting if needed. Dilate the main vessel liberally, stent implantation in the main vessel. Think about stents, about your sizing, and that the sizing should be based on the distal main branch, and also the fact that you need to leave enough stent proximal to the carina so that you can do a pot. When you need to rewire, remember the pullback rewiring technique. Always pass the stent distally and then pull back to recross. Kissing balloon inflation with short balloons is important. And a main vessel balloon size 1:1 according to the distal main vessel diameter. Final pot, and very important, pot efficacy is dependent on how you place the balloon, right? So if you place it too distal across the bifurcation, it doesn't work, and you actually then distort the carina. You need to have it like this, where it's immediately proximal to the carina, and it's reaching the proximal stent edge. So it's not protruding proximally like in the picture on the right. And you know, we all say do the pot, but if it's not done properly, it really doesn't help. It makes the situation worse. And so, you know, another tip is also to know your balloons, because usually most of us pot with an 8mm balloon, and the balloons are different, you know, whether it's an Abbott balloon or Medtronic balloon or a Boston Scientific balloon, as in how much shoulder these balloons have. As far as 2-stent techniques, you know, the Europeans generally are not big time in favor of 2-stent techniques. And really, I think I agree with the fact that it should be done according to anatomy and operator experience. An intentional upfront 2-stent approach represents optimal practice in selected patients with complex lesions involving large and diseased side branches. Meticulous preparation. When you're concerned about the side branch being occluded or reaccess, stent the side branch first, and then the technique, you know, is usually culotte or DK crush, and then the use of pot should be used liberally in part of an optimal 2-stent technique, and final kissing is obligatory. It's almost seen as a measure of procedural quality, because just about every study we've looked at shows that the absence of kissing with two stents is associated with worse outcomes. So I think these are many things you know. It's just a good reminder, and particularly as we go into looking at the cases. So I'm going to stop there, and I'm going to pass it back to Tanveer so we can talk about the cases.
So I'll ask Dawn to comment on this. Dawn, do you have any comments on this?
No, I love the, they're just very simple but practical suggestions and comments on how to do this properly. I mean, these are all key things that everyone that does a high volume of bifurcations sticks to again and again and again. You know, the appropriate sizing of both the stents, the post-dilation balloons, the positioning of the wires, the positioning of the stents. They're fairly simple individually, but when you add them all up, you know, if you don't pay attention to each step, you're not going to have an optimal result. So I love this lecture from Azeem. I think it's right on point with where we need to be.
You know, people who want to do this really have to do it stepwise approach in their mind. They really need to know. Some people write it down before it, or somebody put it in their little board on the board in the cath lab and go step by step if they're not doing enough. But if you don't do it right, remember this, your patient's going to get in trouble. You will have stent thrombosis, and you can't afford it in an area like the left main. Azeem, one quick question. If you want to go back to the pot slide for just a minute, because
Yeah,
you know,
sure.
the illustration did not show where the balloon marker should be, okay?
Yeah.
So
It's
I,
deliberate to
yeah.
not show where the balloon markers are.
Why do you think that's deliberate? I mean, for me, there's a little space, right, before the sort of the tip of the balloon. I sort of I aligned the carina to the marker. Is that wrong? Is that right? Or what do you think?
So the reason it's deliberate, okay, not to put the balloon markers is what I said before. It's really the balloons are different, especially the 8mm balloons, right? The marker and how much shoulder there is outside of the marker is different for all these balloons. And so I think you need to know your balloon. So the EBC, they've actually done bench testing with different balloons, and they've shown that if you put a balloon from a different company, an 8mm balloon at exactly the same place, you get different outcomes in the bifurcation, all right? So I'm just going to stress to you, know your balloon, you know, ask the company to show you pictures of how much shoulder there is from the marker protruding forwards. It's different for different companies.
Agree, but unless I inflate the balloon, how would I know that I'm exactly at the carina? I'm just a little behind it, or I mean, I know exactly what he's saying, but in my mind, without inflating it, how would I know, right?
Because you have to use the marker, but you have to know your balloon. So based on which balloon you're using, either the marker is going to be at the middle of the side branch, or you know, a little bit closer to the proximal part of the carina. I think it's what you say is really important, but it's just not that straightforward because all the companies make their balloons slightly differently.
All right. Don, any comment on that before?
No, I certainly, yeah, the millimeter overhang, certainly there won't be as high pressure during the fall off on the shoulders, but yeah, I totally agree. I've seen some balloons that have minimal overhang, like a millimeter, others have 3 or 4. And if you're unsure of exactly where, you could certainly use imaging to mark it, but you still have to know the balloon. But if you can't tell based on the strut configuration, you can use imaging.
And for attendees, this is very important. No, pot is very important, okay? Very important. So I guess we can go on to the cases. If we stop sharing, I'll share my screen then.
Tanveer, we should also just encourage the attendees to maybe write their questions, you know, and we'll try and address them at the end of each case.
Sure. Sure. So in the chat box, you can put your questions in, and Azeem and Don will look into that. And Azeem and Don, please come closer to the microphone because I can't hear you sometimes too well.
Sure.
So I've got 3 cases which are somewhat similar, and these are non-left main 2-stent techniques. So the first case is a left circumflex OM2 bifurcation treated by DK Coulot. And I'll play this now for you. So this is the This is the vessel. And I'll let the moderators comment on it.
Okay, so here you're looking at a mid-circumflex OM2 bifurcation lesion. It would be helpful to have some additional views of the ostial OM2, but it seems at least a 50% stenosis, so likely a Medina 111 with a very long lesion in the AV groove circumflex. It's probably underfilled, but doesn't supply a large marginal. So the questions to ask would be, what are you considering the main vessel? What are you considering the side branch? And is the strategy a provisional or two stent? And again, if the larger vessel is the OM2, but the more diseased vessel is the AV groove. So those are the challenging aspects of this particular bifurcation.
Yeah,
Azeem?
completely agree, Dawn. It's really a question of how, I think for me, when I look at this, it's how significant do I think that side branch is, and what's the side branch? So I'm going to call, for me, I'm going to call the AV groove the side branch. And then it's a question of how significant or important that side branch is to this patient. And I look at different things. I look at diameter of the vessel, length of the vessel, and territory of distribution, you know. And based on that, you know, I try and make a decision about whether I want to stent it or not. I know you're going to do it. You're going to do a DK culotte. I'm sure it's going to come out beautifully. But if someone were to say to me, you know, I'm going to put 2 wires down and I'm going to try to be provisional on the AV groove circ, I would also think, you know, that would be acceptable to see how that would, what that result would be, especially without not having more information about, you know, how significant that territory is of the AV circ.
Would it be wrong just to stent into that large marginal? So this patient actually was a renal transplant evaluation patient. And this was the only disease she had, okay? The right was okay, I didn't say that. The LED was essentially free of disease. This is the only disease, and it was more than 10%. I think it was close to about 20% lateral wall defect. But this was it, and the question is, should I just have done away with just putting stent down that marginal and be done with a single stent approach, or should I pursue it further?
Yeah, I mean, it's certainly, if you're looking for potentially a short course of DAP 6 months and getting the patient back on the transplant list, I'd be attempting to do a provisional, leaving the AV groove, given it's supplying a small territory. I think the complicating factor is there's the bifurcation lesion and then the subsequent lesion. So there's serial lesions. You certainly want to keep it open. I think if you end up with a 2-stent strategy, then you may delay a little longer, out to a year, but certainly either way would give you a good result.
So as you notice, I did do IVUS on it, and the vessel was 2 millimeters in diameter. So it's sort of beyond the sort of 175 side branch diameter. You think about bifurcation, though the nearest consensus, they said side branch that the operator thinks is important enough and supplies good territory of myocardium. That's somewhat vague, but I did IVUS this, and then based on that, I decided to pursue a 2-stent strategy, knowing that if you consider the continuation on the AV groove, the side branch, it is longer than 10 millimeters, right? And so we definitely need a 2-stent strategy.
So what I might have done, I have to admit, because it's a renal transplant patient and the renal physicians are always like really tough. They want everything revascularized. You know, they're really concerned about it. I might have done FFR instead of IVUS. And if the FFR was negative on that AV circ, I would have just said, you know, to my renal physicians, listen, all she needs is 1 stent here, pre-provisioning, and keep that AV circ open. But I'm sure this is going to look great. But, you know, yeah. I think what this highlights again is that there are different approaches to bifurcations. You can't treat every bifurcation the same.
Yeah. I think just because the serial lesions in the AV groove, I'd be suspicious that it's underfilled right now, and it would be significant hemodynamically. What is it clinically important? I'm not sure, but hemodynamically, I think it would end up significant.
Right.
Yeah. All right. Let's see what happened.
So I put 2 wires down, and I pre-dilated the side branch, which in this case would be the continuation with a 2O balloon, because we knew it was 2O. And
So
then
Tanveer, you basically decided you were going to stent both branches, right?
that's because the side branch is longer. Yeah, I've made a decision.
Absolutely. So which branch, when you do a culotte, which branch do you stent first in your practice?
So you do a side branch first. In this case, I thought the continuation of the circ should be the side branch because the OM2 is a larger branch.
I sometimes choose the more angulated branch, particularly if they're equal distribution.
Yeah, I agree. I also choose the most angulated branch because I keep thinking it will make it easier for me to to rewire into the other branch. And usually the most angulated branch is a side branch. It's just interesting that, we compare sort of the European way, the American way. The BBC study, right, which was one of the first randomized study to compare culotte versus other techniques, they always stented the main vessel first and then did the second stent towards the side branch. And the reasoning was that this way, the main branch is always taken care of. It's always done. I don't do that. I do exactly what you do, Dawn, but it's just interesting again, lack of standardization.
Yeah.
But as Chevalier pointed out, the side branch should always be stented first in culotte, right, Azeem?
Yeah, that's what I do. That's what all three of us do. But just the BBC study, big randomized study, they did it the other way around, and the results were pretty good.
So this is what happened. Then I placed a 225 by 34 DES from the mid-circ down to the continuation in the AV groove. And because I've done an IVUS, I knew that circ in the mid was 3.25, roughly in diameter, 3.3 in diameter. I did a pot with a 3.25 by 8 non-compliant balloon. And this is the post-angiogram.
Can I ask why you chose the culotte rather than just like a mini crush or?
Just trying different things, I think, Dawn. I mean, just the flavor of the day, I guess.
Just the flavor of the day.
And no special reasoning.
Yeah, I mean, the bifurcation angle is not terrible. It's a little narrow, but it's pretty good. So I think you could have done either.
And the other thing was, this business about DK culotte, I'll address that in just a minute, came out and I wanted to try that and see how it worked. So
can I just make one comment?
Yes.
Probably the most important part, so most of us agree we're going to stent the side branch first when doing a culotte, right? For me, probably one of the most important steps of the procedure, which I have to admit, I only figured out much later in my career. Initially, when I did culottes, even in Milano, I didn't do it. And I think I was so silly not to do it, is the picture in the middle. Is that when you do a culotte, okay, and you stent the side branch first, that stent is always going to be so underexpanded for the proximal main branch. And doing a pot before you try and recross is, to me, probably like one of the most important caveats of doing a proper culotte. And I just wanted to make sure that the audience saw this, because this is just so well done and it's important. Don't miss this step.
Yeah, no, I agree. And I think it's partly because the pot didn't take off until DK crush and more later techniques. And this is an older technique, but it's so important to apply it.
And this was a post-angiogram that you see after doing the pot. And then this is what we did. We did a strut dilatation of the 2.5 balloon to that marginal. And then did the first kissing balloon inflation, which is different from regular culotte. This is new. First kissing balloon inflation made a double kiss culotte. So you've got to do the first kissing balloon before you insert the other stent, okay? So this is the different part. This is the new thing about DK culotte, which causes better expansion of those cells, okay? Any comment by the moderators?
No, I love it. I love the concept of applying that additional kissing balloon, because it certainly seems it would make it safer, easier, better outcome when you place that second stent.
Then I took and obviously we have to after the left circ wire is removed and repositioned, because you don't want to jail the wire. You have you put the stent at 3.25 DS, going through stent struts. Remember, it was not a long lesion, so it just went in by a few millimeters. and it came back to the original stent. So guys, do you pull this stent back above the original stent, or do you keep it in the confines of the previous stent?
Yeah, so my approach, and I was just doing this with the fellows, I think yesterday, the day before, is I protrude my side branch stent less than the main branch stent. So I always try and cover, with the second stent, which is my main vessel stent, I always try and cover all of the side branch stent. Okay, and the reason I do that is because they're two stent layers, I want the first stent as well opposed as possible. So I really do, a mini culotte as much as possible with my side branch stent protruding as little as possible, and then cover that entire side branch stent and the rest of the lesion with my main vessel stent. That's the way I do it.
So one thing, I'm sorry, we did remove the wire before I stented so it not get trapped. So after this stent is placed, and by the way, Azeem, I did pull the stent margin just above the original stent. Maybe I was wrong doing that, but I did it that way. I was worried a little bit about the stent edge from the first stent. That's why I did it, okay? But after deployment of stent and rewiring, this is what it looks like, before that. This is a pod balloon coming back. Actually, but you can see the stent struts sort of flaring out the side branch. And you see the stents, going to side branch. This is before the pot even.
I think when you took that, did you wish you had a couple more millimeters going into the marginal?
No, I think we're okay, to be honest with you.
Yeah, it's just, certainly the rest of the vessel's normal. In order to avoid any geographic miss, I probably would have just added a couple of millimeters on there, but sometimes it's difficult to judge the size.
Yeah, I agree with you, John. I probably would have too, especially distally. And the reason I would have is just because of my my final kiss. I just want to be sure that I can get enough balloon on each side across the carine. And the side branch, you have a lot of balloon you can put, but the main branch, you need, yeah. But I think looking at the picture on the right, it looks pretty good though. I mean, you can get across fairly well with the balloon.
Let's come back with the same pod balloon, 3.248. Did the pod, then I went to by the 2.25 non-compliant balloon, did through the struts, 2 layers of struts, did high pressure balloon, the continuation heavy groove. That did the high pressure with the 2.5 non-compliant balloon in the cert marginal. And then followed that with, so it has to be high pressure dilatation, second balloon inflation, kissing balloon inflation, the same balloons, then ended up with the final pot. So remember the 3 pots. The first pot to dilate the proximal end of the stent that went to the AV groove. The second pot after you deployed the side branch stent, and after you deployed the AV OM2 stent, and the third and final pot at the end of the procedure. So this is the third pot being done. So DK culotte has 3 pots, okay? And this is the final result.
Yeah, it's a beautiful angiographic result. I think you had certainly a little bit of balloon overhang outside of that stent, but it looks like a 3-5 vessel. Probably you're not going to have an issue there. That smaller marginal held in there, and the flow is great. The ostium of that smaller marginal looks great despite the 2 layers of stent, which is always a concern with this technique as opposed to the DK crush, but it looks phenomenal.
Yeah, I like the result too. I would have obviously, and I know you did it. You did imaging, I'm sure, at the end. Because
so yeah, I had the imaging. Unfortunately, it's somehow we're transitioning to a different vendor. It got lost in the system, and I apologize for not showing it. But I did.
I just think, as a message for the younger attendings, who are listening, is I honestly don't believe you should ever do 2 stents on a bifurcation without doing final imaging. If you're not prepared to do the imaging, you shouldn't do 2 stents on a bifurcation. I think it was Colombo who would always say to the fellows that when you do 2 stents on a bifurcation, you take on the responsibility, a huge responsibility, because let's not forget that no matter what people say, there's a slightly higher risk of stent thrombosis with 2 stents. So you really, like Tanveer did, do imaging at the end and make sure that you have a great result.
So the next case is similar anatomy. So it's an older guy who declined cabbage. I fixed his LAD some days prior to coming for this left circle 2 bifurcation, which I treated with the DK crush technique. So this is a sort of similar anatomy, but the continuation in the AV groove to the PLM is a somewhat larger size vessel, but somewhat similar anatomy. So any comments by the moderator?
Yeah, no, I agree. The anatomy is very similar. You've got the dominant branch being the first marginal, but you've got a very long or serial lesions in the subsequent AV groove going into the next marginal. Patient also appears to have a bifurcating very high OM, which could have some disease, but it doesn't look too bad. But I agree. I would approach this with a 2-stent strategy. And again, you know, choosing which one is your main vessel and which approach. The bifurcation angle is a bit narrow. I think certainly a DK crush or the DK culotte are options.
Yeah, I couldn't agree more. I think this one I also, even my European side I'd suppress it and I'd do 2 stents. Yeah, I think this is a bifurcation that needs 2 stents.
Are you guys have any chat questions by any chance? I can't see the
No.
feature.
No, it's a quiet crew. Even I see some of my fellows on here. I should ask them to ask some questions.
So again, 2 wires. I think I use run-throughs of 2 run-throughs.
I just usually choose one run through and one like Pro Water or Xi'an Blue or something different so I know I can tell them apart.
We needed color-coded wires.
I need them color coded, yeah.
So again, pre-dilatation of the continuation of the circumflex, more distally and then proximally, and also pre-dilatation of the side branch or the marginal.
Tanveer, I forgot to ask on both cases, what size guides are you using and what excess side are you from?
Oh,
Are you from radial or femoral?
I go radial, 6 French.
Okay, 6 French radial.
Yeah.
Great. I mean, that's also another important message for those listening. I think all these techniques, even in left main, you can do with via the radial and most times with 6 French.
Yeah, once you get over a 3-0 vessels though, it's just really hard with the kissing, and I would, from the radial, use either a sheathless guide, which is 7.5 French and only 5.5 outer diameter and comes in certain shapes, or we use a 7 slender. Most patients can accommodate that. It's equivalent to a 6 French and a 7 French guide. Sometimes it's a smaller woman, you'll have to use sheathless, but it just makes visualization and movement of the equipment easier. But radial is certainly feasible with up to 7.5 French.
I mean, the thing is that Medtronic guides are pretty large, but I think
yeah, a little larger, yeah. Yeah, we mostly have cordis, so we upsize sooner.
So this is what we did, pre-dilatation of both. And then we, with a balloon present in the circ, which I parked distally for the moment, like a 2.5 balloon distally, I positioned the side branch stent or marginal stent with a drug-eluting stent. And the way to know how much protrusion you should have inside the major vessel, the wire that runs along the AV groove, for example, is a good marker. And if your stent marker just sort of meets it, you are comfortably within 2 or 3 millimeters within the vessel. Any comments, Don or Azeem, about that?
No, agree. I try not to have too much to 2 millimeters. You can use your other wire if you need to use location, but.
So now if you've noticed, pull the balloon, the AV groove back just so that I don't have trouble recrossing later on. And I've inflated the stent, but I've done a little bit more. So this is second inflation after the stent was deployed. I actually brought the stent balloon back a little bit into the parent vessel and did a proximal stent optimization or PSO, something that Dr. Lavara talks about. And I noticed he's one of the participants today.
Yeah,
go ahead.
The same pairing technique, yeah, for sure. And really important to have an appropriately sized balloon to crush the struts. If you're very undersized, that's when you'll run into a problem, bringing a new device or stent into the other vessel.
Yeah. So I just want to re-highlight what Dawn just said. I mean, Dawn, you always give these like amazing pearls. So I hope you don't mind if I jump on your pearl. To me, again, in both techniques, there's one of the things that I've learned over the years that makes the biggest impact, right? So in the culotte, I talked about the pot after your side branch stent. In the DK crush, and we did hundreds and hundreds, and the thing that's most impactful is just what Dawn said. It's using an appropriately sized balloon at high pressure to really crush your stent before you even try and recross, let alone getting your other stents across. Your recross into the side branch will be so much easier if you've crushed that first stent properly. So I can't highlight it enough, what you just said, Dawn.
Yeah, exactly. Otherwise, when you rewire, you don't know what the course is. You could be in the middle of it or through both of them. You don't really know. So
before we crush, the proximal stent optimization by bringing the balloon back is really to widen the stent so that even after you crush it, you can have reasonably easy access. So that's what we did. So we have done that, okay. And then after we remove the stent balloon guide wire from the second marginal, we do a balloon crush, okay. So some people say do it with what the pot balloon is going to be eventually. But remember, the end of the mark for the pot balloon should be just at the carina, as Azeem just recommends. So you notice, obviously I've not shown you the cine, but I sort of, the marker is just, this is a Medtronic balloon, so there's a little shoulder to that. So the marker is right at the carina, crushing that stent. Would you, what are your thoughts on that again, Azeem or Don?
For the crush, I don't get too concerned. I would go straight across unless there's a huge size discrepancy in the proximal main vessel to the distal main vessel. I'm worried about dissection, in which case I would place it like you did. But otherwise, for the initial crush, I'm pretty liberal about the positioning.
Yeah, I do the same. I go across the bifurcation with a balloon that's the same size as the stent I'm about to implant into the main branch. And I go to pretty high pressure doing that.
Okay, so next is the after that we do the proximal rewiring.
So Tanveer, let me stop you here, right? Because
yes,
this is kind of for crush, and I mean, the whole reason we all started doing DK crush was with the classical crush. This was the hardest part of the procedure, crossing into the side branch of the balloon. But even with a DK crush, it can sometimes be challenging. So maybe some tips and tricks for the audience on what everybody does when they can't cross into their crush stent in the side branch. Dawn?
Yeah, so you can pull back your main vessel to cross, but main vessel wire, but be cautious because you don't want to lose access to that. Certainly if it's a large vessel or a strange angle, I might use something like a Suzuki, or just keep changing the angle on my, the curve on the wire I'm using. I don't tend to switch to a hydrophilic wire unless I've tried a couple of different shapes on my workhorse wire, but that's also an option. And then, sometimes you take what you can get in terms of the positioning if you can't get through what you're aiming for in the optimal strut. But there's so many different techniques you can use to recross successfully.
So one of the things, if you're away from the carina, you're probably proximal. There's a poor man's view of that. But once you do that, you balloon dilate the OM2 stent struts. And after you do that, you do the first kissing balloon inflation. Okay. And then you again pull your hardware out of the marginal. And
so I have to ask, is this the ultra long synergy, or this stent looks longer than any stent?
No, this is not a synergy. This is a 38 millimeter onyx.
Oh, it just looks so long. I thought it was longer than anyone that we carried, but it's
so
standard.
We put
38.
this long onyx in, okay, and inflated it. And then we did the pot, okay? Pot balloon again with tip of the carina. You can see that in this view, okay? Maybe I'm a little short of the corona, but I think I'm pretty close. And I did the inflation here.
Yeah, it depends on your balloon overhang, but you know, whether the positioning is, it looks, you know, maybe a millimeter off, but you have very little overhang on this balloon.
And then again, the OM2 is rewired. With redilatation of the struts. Second redilatation. The second kissing balloon inflation. And final pot. And the final result.
Well, you make it look easy. These are two phenomenal results, like really large lumen results. Very nice.
So in decay crush, there are really two parts, but if you use the initial pod balloon sized by Ivis, you can use the same pod balloon for the initial crush, can you not, guys? Then that make it 3-part then, right?
Yeah, it just depends on the length you want to use because and how far back you're going in the main vessel, because sometimes you're stuck using a very short pot, like a 6 or an 8. And I don't tend to use those for the initial crush. I tend to use longer. Maybe it's just being lazy, but it's just to have a little more leeway in the positioning. Is an option. Certainly if you're going to have a longer segment of the main vessel, you can use the same balloon.
Yeah, great results. And I'm also gonna again assume you did imaging here at the end, right?
Yes, yeah, I did do imaging, and I'm sorry once again that that file could not be retrieved. But I think I'll show it on the third one though. Okay, so anyway, so next case is a little different, but again, it's a 2-stent technique. It's again one of the renal. So this lady needed a combined liver kidney transplant and came with an abnormal imaging study. And this is 45-year-old female with IgA nephropathy. She's had bilateral nephrectomy. She's had recurrent peritonitis, has hypothyroidism and gout, worsening fatigue, eval for renal transplant. EF is normal. She has moderate tricuspid regurgitation with RV systolic pressure in the 40s. And this is her diagnostic angiogram. So right off the bat, you can see there's an eccentric lesion, the calcified region, the LAD proximal to mid portion. And you can see the calcification even before you inject the vessel. It's heavy calcification. And this is the sort of the AP cranial view, not the best view. You can see that initial lesion in the mid portion. And again, there's a lesion, probably a type of trifurcation, large septal, large diagonal. A funny LAD that goes to the lateral wall. This large septal could be a parallel LAD. Any comments, guys? Or?
Yeah, it's a very large diameter vessel. And it's not diseased, so I think keeping it simple more on the bifurcation, and I think favorably the extent of disease in that diagonal branch is it's a very short lesion. So I think in this case, strategy, you do. It's a very large diameter vessel as well.
Yeah, I agree with you, Dawn. I'm also going to try and keep it as simple. I think that sort of large septal branch looks pretty big, but in this view, it doesn't look diseased at all. So
I'll show you a better view. I'll show you a better view of the guider in just a minute.
Okay, 2 wires, one down the LAD, one down the diagonal, predilate aggressively the main branch and stent the main branch and see what the side branch looks like. Maybe do a final kiss and try and do sort of a provisional.
The right was okay. And look at the amount of calcium in the left and the LAD on the fluoroscopy there. So the question was CABG versus PCI. because of the complicated LED stenosis. She's a renal failure patient. Of course, Lima engraftment of which vessel is a parallel LED. And the technique, bifurcation technique, is calcified, do you rota or not, and which LED to treat if you think the LED is a parallel vessel. So we did review the case of the heart team, and due to frailty and comorbidities and patient request, PCI was preferred for CABG.
I think
So-
also if you did a syntax score and a syntax 2, you would end up with probably a recommendation that either strategy is equivalent. You know, because it's complex, but it's still relatively isolated.
Will this view change your minds about anything?
Well, here certainly the diag looks much more severe and at risk of closure. There's certainly a little suggestion. I think with the septal, it's just the narrow angle is what is, but I still don't think it's heavily diseased, making it a trifurcation. You could certainly wire it as a precaution. You know, so I think given that sort of unfavorable angle and very tight stenosis in the diag, you could a DK crush or a DK culotte, but you could still try a provisional, but I'm a little less hopeful you're going to get a good result because it does look so severe, like 90%. And the calcification, I think, you know, these are large vessels. I'd like imaging to see whether it's deep calcium, how circumferential. I don't know if you had IVL at the time of this or not.
I didn't have IVL at the time.
Yeah.
But in the first diagnosis, also diseased at the origin. But in terms of the LED, do you think it's a parallel LED or do you think it's still a large septal? Look at the perforators being given off. The LED
Yeah, exactly. Yeah. I think it's probably because that other vessel is going more to the apical lateral wall.
So there's a short LED and there's a large diagonal. Is that it?
Yeah, I must admit, I'm still gonna favor a provisional approach here. The only difference I'm gonna take is whereas before, because I couldn't see that osteal disease, I wasn't gonna predilate the side branch. I would now predilate and still try and be provisional. I don't know. Like I say, it's just so focal that it looks like you may get away with provisional. You know, I like the idea of IVL, Dawn. It's really, for these kind of lesions, it's been a little bit of a game changer because you can keep both wires down and really treat the calcium. You know, what may be interesting in the future, we don't have it here in the US yet, but when we get drug-coated balloons approved here, you know, whether you can do a case like this with a stent in the main vessel and a drug-coated balloon towards the side branch. We did that a lot, and we do it, and people in Europe do that a lot, and I certainly used to do that a lot with really great outcomes when you have focal disease. But it's a big side branch. I don't think, you know, anybody's gonna say it's wrong or you did something bad if you're actually worried about losing it and you decide to stent it.
So which do you think? What do you think is the LED, Azeem, in your mind?
What I think about it, as in what?
Which is the LED in your mind? Which vessel?
Yeah. So for me, I think I'm probably going to do the one in the middle. The vessel in the middle there is where I'm going to stent down. Okay. When I have issues and I think there's a trifurcation, I have concerns. I mean, I trained with Antonio, so I stick wires down everywhere because I really believe wires protect. So if I was worried about that septal dual LAD vessel, I just stick a wire down, and be sure that I have access to it.
Yeah, okay. I agree. I would stent into the vessel that's the medial, the middle.
See, I may not have this in order, but I do have an IVUS pre, but the IVUS got stuck in the mid lesion. I would not cross, and there's circumferential 360 degrees of calcium. It's on the slide, but I think it may not be in the right order. So I ended up doing a rota with a 1.5 burr and down that LAD.
Are you 7 French here? Because the guide looks a little bigger because it's such a big vessel.
6 French.
6 French, yeah. Because otherwise, maybe take a 1.75.
So, yeah, you're right. We're shifting to 1.75 burr, but I took a 1.5 burr.
Well, because you're 6.
Yeah. No, 1.75 will go through
yeah,
6 French.
We'll go in 6.
It's a little, it's tight in the Cordis guide.
So actually, this was a pre. I was actually where I was just stuck there. This is before the road up, and I could not cross this area with the IVUS. Now you may say, the style of the IVUS catheter may have precluded that, but there certainly is a lot of calcium around there, and I could not go beyond the mid portion.
It looked about two. It's just the diameter is large. That's why, I guess you could have chosen a bigger burr or CSI, but yeah, definitely with some wire bias, you'll get some debulking.
After that, I wired the first diagonal, which was pinched, and not the other diagonal. I left the wire in the main vessel here. I left this large septal alone, rightfully or wrong. Ballooned it and then stented it. I think I took a 325 stent, 325 by 30 stent, and used a 3.5 balloon for pot, approximately.
I'm not too worried about the septal/dual LED. It didn't optional. And I think once you have 3 wires, you don't really want 4.
Yeah, that's correct.
It's really hard to manage, and they're going to get wrapped at some point.
So this is the.
Yeah, I agree. I think you were better off protecting that first diagonal that came off at a pretty, acute angle. There was some osteal disease rather than that septal.
So I did that, but I jailed it. I jailed both wires, and here's
Yeah.
what the stent result looks like. The osteal diagonal doesn't look pretty still. And going back to Dawn's point of view, should have considered 2 stent techniques. The reason I didn't do that, I wanted to keep it simple, at least in renal failure patients with 1 stent, less likely chance of stent thrombosis. The side branch is narrow, was less than 5 millimeters in length. So that's why I chose a provisional approach and hoped that pot would open up struts to the diagonal side branch. But that didn't.
And I think if you do provisional and then you have to do a tap, you're perfectly fine. It'd be a really nice result. So provisional is fine when it's a favorable angle and it's less than 5 millimeters. I don't think there's any question about that.
So then I went back with a 375 non-compliant balloon to pot, and even then the appearance did not change. So I took the first diagonal wire out, rewired the side branch, and did a side branch dilatation with a 2.5 balloon. And again, did a repot. So I did a pot with 375 balloon, side branch dilatation, and repot rather than kissing balloon, okay? And still, it did not change much. It didn't change much at all, okay? Okay, so I still don't want to put a second stent in. And I then decide to do a kiss. Now my wire is redirected to the other side, but I should have repositioned it. Very important, otherwise I would have perf. But anyway.
Yeah, I mean, it angiographically only looks about, I don't know, 50% at this point. You might be hemodynamically fine. So that's another option to check that.
Okay.
Check an IFR.
Guess what? I put an IFR wire down. It's not hemodynamically stable. It's 0.84. Leave it alone? Or tap it?
I mean, I think since you've got sorry, Dawn.
Yeah, I was going to say, usually I'll use the cutoff of 0.89. I mean, certainly there's a gradient. We don't have a pre-reading to know whether it's, whether that territory is going to be clinically meaningful, but it is. This is
a large diagonal though, it's not small.
No, exactly. So I think at this point I would have gone ahead with the tap.
And if you look at the circ is kind of small.
Yeah.
Yep.
So I did a kissing balloon and then I did a tap, and so put the stent through the struts. Again, the marker should just barely touching the wire in the main branch. There should be a balloon across, currently positioned distally to bring back while you're inflating the stent so it does not get trapped distally and allows passage of a balloon in the future. Did the tap, pull the tap balloon, put the stent back, the stent balloon back, and did a kiss, and then ended up with the final pot. So to do tap, you put the stent through, position correctly, inflate the stent balloon, then bring the stent balloon back, inflate the balloon in the main vessel to high pressures, inflate the stent balloon at high pressure the ostium, and then do simultaneous inflation. So I go to 16 on the side branch, 16 in the main vessel. Then when I do simultaneously, I do 8 to 10 or 10 or so simultaneously, then simultaneously deflate, then end with the part of this 375 balloon that I used before. And I think this is the final IVUS.
Yeah, I think that was just a very smart approach to this, trying to keep it simple, and then certainly a very reasonable bailout strategy for suboptimal provisional result.
I'm going to show you something where the stent protrudes just a little bit to side branch.
Is this the eagle eye, or which IVUS is this?
The eagle eye.
Yeah.
So here's the tap stent. Can you see this?
Mhm.
It's actually not protruding that much in the lumen. Sometimes really protrudes out, but this is what the origin of the side branch looks like. There's still some stent struts overhanging there. So I've not really extended the stent that far back in that I should have into the main lumen, but I'm going to accept this. Any comments here, guys?
Yeah, I don't think you have any uncovered area, which is the key. You just don't want to leave uncovered vessel. I don't think you have any here.
So this thing that protrudes in the lumen, nothing will show up in the final angiogram, but the stent is well expanded, okay? And it's just only in the main vessel and proximally.
Yeah, if you don't see that sort of almost figure of 8 at the carina, it means you've probably missed the bifurcation and you're too distal. So I think the fact that you showed it looks good.
But you know, to go back to my positioning, I think I did. Let me just go back a few slides.
I think the part people struggle with the most when it comes to a tap is really the positioning, because if you do come back too much, it just is then there's a lot of stress protruding.
So look at my position. My position is not wrong. The tip barely touches the wire. There's enough stent in the main vessel.
This is a Medtronic stent, right?
Yeah, these are Onyx.
Yeah, because you can see. I mean, it's the other important part with taps, right? Is knowing your stent, because here you can see nicely the space between the marker and the stent. So you need to just look more at that rather than just the marker.
But the stent is crossed over enough, don't you think so? The main.
I think it looks really good. Yeah.
No, I think it's perfect.
And the IVUS proves that. So, I mean, there's a question that always comes up. When you do a tap, right? So I do it like you do. I deploy my stent in the side branch. I then pull it slightly back, and I do my kiss with my main branch balloon. Does it make a difference which balloon you deflate first?
But I think they say deflate both simultaneously, don't they? I mean, that's what.
Yeah, you just have to be careful. I think if you have a very short, if you have a small side branch, so if you have like a 3.5 main branch and a 2.5 side branch balloon, you just have to be a little careful because smaller balloons deflate quicker. So we actually published a case where we showed that because we deflated both together and the side branch balloon deflated first, the main branch balloon pushed and almost crushed those struts of the side branch stem. The patient came back, 2 months later with restenosis at the ostium, and we looked at it, and it was just this under expansion or these stents that got crushed by the main vessel balloon. So it's just something to consider.
And despite the high pressure in the individual branches, it just moved it at the end.
It moved it right at the end. So what I do is I literally I deflate almost simultaneously. I go main branch and then side branch, right? One right after the other, just so that it doesn't happen to me again. So that's the one thing I do. The other thing, just probably to mention, I really do think when you have to convert from provisional to a two-stent technique, the tap is the easiest. Obviously, there's less recrossing. It makes your life so much easier. The only other technique I use at times when I have to cross over is I will use a reverse culotte. I don't do crushes ever when I cross over, and I don't think you should. because you never really can be sure that those crush struts are as well opposed as they need to be.
No, completely agree. It's it just seems like it would cause some flow disturbance or nidus for thrombosis. So
Agree. So should you use this 10 delivery balloon to do simultaneous kissing balloon, or do you go with a non-compliant balloon at the end?
I keep it simple. I have my non-compliant balloon and the stent balloon, and I do my kiss with that. That's what I do. I mean, it's kind of why I like the tap, is because it's just, it's quick and I'm out of there.
Yeah, but I think if you see angiographically it looks underdeployed or by imaging, then I would go back with a second kiss with an NC. The good thing, the first diagram branch stayed patent, and actually this parallel LED looks longer now that we've opened everything up. Yeah, it looks perfect. Yeah, I don't see any compromise. So as well, the first diagonal started looking great too. So those are amazing. And how do you guys deal with the, you do a lot of transplant patients who may have silent ischemia, or how do you do with your appropriate use? Because we published from NCDR that high volume transplant centers have a higher frequency of rarely appropriate PCI. You and I were in the paper together, Don, if you remember. Yeah. I think, we have, when Manish Patel was in charge, I think we had this, we talked to NCDR, as you know, and said, we've got to do this, particularly in transplant centers. I don't think we've had any penalty for that. I doubt we will. But I do think our paper that we published in JAMA was very helpful. But we are high volume, both liver and kidney transplant. My main worry is that these people wait on so long, and you do another stress test in 2 years, they're going to be positive. When you go back in again and they're restenosis or something bad has happened to them. But I try to keep it simple with just one stent if I can. So you mostly go by their stress test ischemic burden. Yeah, because they would not do it otherwise, Yeah. And no, the renal guys are a little better. They say, oh, we have a CTO, one vessel, the other vessel's okay, LV function is okay, they'll go with it. But the liver team and others, they're very stringent. They just don't want any kind of cardiac disease at all. It's basically, let's look at.
So let me ask, the other issue, what do you guys do? Because we're kind of limited. When you get, any of the techniques you showed, DK crush or DK culotte, when you get restenosis at the bifurcation.
Tanveer? When you get restenosis, is that what your question?
Yeah. What's your approach to restenosis?
I think the first time around, particularly in this population, I've seen a lot more restenosis. Renal failure is just bad karma. It'll restenose. And cabbage, the cabbage guys surgeons don't want to do it because renal failure, they have such a high bleeding complication. They just do not touch it. So if I've had a good result, and many times I've had a real good result confirmed by IVUS, it still comes back. I don't put a second layer of stents. I just go back and do high pressure dilatation. And occasionally I've taken if it's a large enough vessel, particularly left main circumference bifurcation, I take a large peripheral drug-coated balloon, and I just put it in partially in the left main to the LED. And some of these people have not come back. So we're waiting for the drug-coated balloon. But I don't try to put another layer in, Azeem. I just don't. Perhaps push the surgeon at that time, please do something. Now they say we're never going to touch this patient, the patient having an intractable angina. Some of these people have kept on coming back over and over again, and people have put layers of stents, which I don't think is the right thing to do, in my opinion.
Sure, I sorry, Dawn, go ahead.
No, I was going to say I agree, and certainly if imaging wasn't done the first time, you can image and find out if somehow was underexpanded or underdeployed. And sometimes you find out it's not a lot of intimal hyperplasia. It's like what you said, it's somehow the stent recoiled or didn't end up as optimally expanded. So in that case, you could consider laser, but that could actually precipitate more restenosis in the future. It's unclear. But we do use it if we can't fully dilate or if there's a lot of tissue we want to ablate. And we are starting in the US, Bobby A is leading an instant restenosis paclitaxel balloon trial. So hopefully, that will be available.
Do you have small sizes in the paclitaxel balloon available in this country, in the peripheral armamentum?
No, no. Mm-mm.
Well, the
4
coronary one, again, comes as small as 2 millimeters,
Mhm.
right? And so certainly in the agent IDE, which is the first randomized trial starting now with restenosis with drug-coated balloons, they're balloons from 2 to 4 millimeters, which is great. The only problem is you probably wouldn't be able to get a patient with 2 stents in the bifurcation in, because I think it's a contraindication because
Yeah.
there's such a high risk of repeat restenosis. And that's why, the reason I ask it is because I think you both highlighted the fact that we don't have a great solution when these restenosis. I mean, in Europe, you can do kissing drug-coated balloons, and we would do that often, especially on left mains, even LED diagonal bifurcations. But I think the best way to treat 2-stent restenosis of the bifurcation is to really make sure you have a great result in the beginning. And that means, like you saw with Tanveer, aggressive lesion preparation, and make sure you have, do all the steps right, because there are a lot of steps when you do 2 stents and it's easy to mess them up. And then do imaging and make sure you really have gotten the stents as well opposed and expanded as you can.
So thank you very much. I hope this was interesting for the audience. We're going to be taking a 3-month hiatus and regroup. We're trying to expand the program and add additions that involve more young, early career people and probably have occasional live cases. So we're working on that. And I thank Elisa, who's going to go on leave for a few months too. And good luck with your baby. And thank you very much, Don and Azeem and Elisa, for making this happen. Thank you very much. And
Yeah, congratulations on those cases.
thank you so much. Bye now.
Great. Thank you, everybody. Good to see you. Bye-bye. Thanks for joining.